My cardiac pharmacological agent is digoxin, or known by its brand name Lanoxin, Digox, Lanoxin Pediatric, and Digitech. This drug derives from a plant called common foxglove, Digitalis purpurea. It can be administered by oral or intravenous if needed rapidly. Digoxin's half-life is 40 hours and its pharmacologic class is a cardiac glycoside. Cardiac glycosides are a class of organic compounds that increase the output force of the heart and decrease its rate of contractions by acting on the cellular sodium-potassium ATPase pump. Digoxin is a colorless to white crystal substance or can be a white crystalline powder. Its therapeutic class is an antiarrhythmic. It is an odorless, bitter drug that can be insoluble in water and ether, slightly in alcohol, and freely soluble in pyridine. Digoxin's molecular formula is 41 carbons, 64 hydrogen, and 14 oxygen, with a molecular weight of 780 grams per mole. Its chemical classification is a cardiac glycoside that consists of 3 sugars and the aglycone digoxinin. Digoxin's functions include a positive inotropic effect, which increases the force of myocardial contraction. It has a negative chronotropic activity that decreases the heart rate. It has a vagomimetic effect that decreases the rate of sinus node discharge, atrial conduction, and atrioventricular nodal conduction by prolonging conduction times and refractory periods of these tissues, thereby forming the basis for digoxin's effectiveness at controlling ventricular response to supraventricular arrhythmias. By slowing down the conduction in the AV node and increasing its refractory period, digoxin can reduce the ventricular rate. It can also reduce sympathetic nerve activity, renin-angiotensin activity, circulating catecholamines, and regulates baroreceptor function by increasing vagal tone. Mechanisms of action. Digoxin has a positive inotropic effect that blocks or slows down the sodium-potassium ATPase. It inhibits the sodium-potassium ATPase pump in mitochondrial cells. This pump transports 3 sodium ions out of the cell and transports 2 potassium ions within the cell. Digoxin inhibits the site, causing it to be blocked. This causes a buildup of intracellular sodium ions and not allows potassium to enter at all. This buildup activates the sodium-calcium exchanger, which removes 3 sodium ions for 1 extracellular calcium ion. This leads to a buildup of intracellular calcium ions, which then leads to an increase in inotropy, or strength of contraction, and may promote activation of contractile proteins, such as actin and myosin. This also leads to an increased ejection fraction. Digoxin also acts on the electrical activity of the heart, increasing the slope of phase 4 depolarization, shortening the action potential duration, and decrease the maximal diastolic potential. Common uses of digoxin include atrial fibrillation, atrial flutter, and heart failure. It does this by increasing inotropy and ejection fraction, decreases preload and pulmonary congestion. It also treats systolic dysfunction that results in congestive heart failure, including dilated cardiomyopathy and end-stage left ventricular volume overload. It is also used as ventricular rate control in treating supraventricular tachyarrhythmias such as atrial fibrillation, proximal atrial tachycardia, and atrial flutter. Uncommon uses of digoxin include late-term abortions. It is used by physicians intrafetally or amniotically during abortions in the late 2nd trimester and 3rd trimester of pregnancy. Digoxin has a very narrow therapeutic window. Too high of a dosage will cause cardiac arrhythmias and cause toxicity. Too low will not have the same effect needed. The long half-life of digitalis compounds necessitates special considerations when dosing. With a half-life of 40 hours, digoxin would require several days of constant dosing to reach steady-state therapeutic plasma levels. For digoxin, The therapeutic plasma concentration range is 0.5 to 1.5 nanograms per milliliter. It is very important that the therapeutic plasma levels are not exceeded because digitalis compounds have a relatively narrow therapeutic safety window. Plasma concentrations above 2.0 nanograms per milliliter can lead to digitalis toxicity. Digoxin is readily absorbed, undergoes minimal hepatic metabolism, and is excreted almost entirely by the kidneys. A high dosage of digoxin can cause toxicity. This will lead to ventricular tachycardia or ventricular fibrillation or progressive bradyarrhythmias or heart block. This can also cause disturbance of color vision, mostly yellow and green, called xanthropsia. It also has a generalized blurry vision as well as seeing a halo around each point of light. Class 1A antiarrhythmic, quinidine, competes with digoxin for binding sites and depresses renal clearance of digoxin. These effects increase digoxin levels and can produce toxicity. Similar interactions occur with calcium channel blockers and non-steroidal anti-inflammatory drugs. Other drugs that interact with digitalis compounds are amiodarone, a class 3 antiarrhythmic, and beta blockers. Diuretics can indirectly interact with digoxin because of their potential for decreasing plasma potassium levels, producing hypokalemia. Hypokalemia results in increased digoxin binding to the sodium-potassium ATPase and thereby enhances digoxin's therapeutic and toxic effects. Hypercalcemia enhances digitalis, which can increase intracellular calcium, leading to a calcium overload, inducing arrhythmias. Hypomagnesemia also sensitizes the heart to digitalis-induced arrhythmias. Digoxin has a direct and indirect effect on electrical activity, including SA and AV nodes, and slows down ventricular rate in AFib. In low therapeutic concentrations, it does not have an effect on the AV node directly. It acts indirectly via increased vagal influences and decreased sympathetic influences. It slows AV conduction and variably decreases the sinus rate. At toxic concentrations, the indirect effects combine with direct conduction inhibit on SA and AV nodes, resulting in sinus arrest, bradycardias, high-degree AV block. In low concentrations in atrial conduction fibers, Purkinje, atrial, and ventricular muscle has an increased slope of phase 4 depolarization, decreasing resting potential and decreasing ADP. This combination of effects produces the Dig effect on an EKG. In one major study of patients with heart failure, the Dig trial, digoxin did not reduce the risk of death, but did reduce the likelihood of being admitted to a hospital. A series of studies have followed which show digoxin increases the risk of death. In a systematic review and meta-analysis of observational and controlled trial data, authors wanted to assess all studies published on digoxin in order to better appreciate whether digoxin improves or worsens clinical outcomes in heart failure, atrial fibrillation, and a combination of these two. Results found that in clinical trials, where treatments are randomly assigned, digoxin does not increase or reduce the risk of death. In patients with heart failure, digoxin reduced the need for hospitalization. Unfortunately, there was very little good quality data in patients with atrial fibrillation, highlighting the need for further clinical trials in this area. They also identified that studies just observing what happens in normal clinical practice without randomly assigning treatments should not be used to look at the treatment effects of medications. In these studies, there was a clear indication of bias due to marked differences in the types of patients who received digoxin. They are usually much older, with more diabetes and worse heart failure, all of which are themselves associated with an increased risk of death. The author's review of all published data on digoxin suggests that it does not cause death, may reduce the need of hospital admission, and should continue to be considered as a treatment option in patients with heart failure and atrial fibrillation. A 75-year-old woman came into the emergency room due to confusion and nausea for the past 2 weeks. She reported signs of not eating and also of vomiting. She showed signs of shortness of breath, dizziness, sleepiness, and confusions. Her heart rate fluctuated between 35 and 50 beats per minute, with a blood pressure of 175/100. Her respiratory rate was 14 breaths per minute with normal blood gas results and no signs of fever. The physician determined she was having heart failure and prescribed digoxin due to its positive inotropic effects and negative chronotropic activity.